Okay, you're on.
Good afternoon, everybody. This is Dana Harganani, Chief Medical Officer for the Oregon Health Authority. Today's our weekly webinar for healthcare providers on COVID-19 that we host here at the Oregon Health Authority. I'm joined by my colleagues today, Dr. Tom Jean and Dr. Ariel Smits, who can introduce their specific roles as they're presenting with me today. Again, just format for these, we unfortunately are unable to respond to real-time questions during the webinar based on how we are set up here, but we are collecting those questions. We use those to populate our webinar content for the following Thursday and the following week. So please do go ahead and submit any questions. Know that we are capturing them. We will be posting slides and the webinar recording on our website as well. So for today, the agenda items that we have captured, you'll notice these continue to recur as there's ongoing updated and new guidance happening, and certainly ongoing intention and questions on all of these topics. So those that we're honing in on today, again, we'll give you our updated numbers as of yesterday, our testing updated guidance and some Q&A related to that. We'll talk about personal protective equipment and new guidance we just put out regarding use of PPE and approaches to managing various constraint environments regarding resources. We're going to tell you a little bit about the updated guidance on elective and non-elective procedures that were just recently released. We'll then go through some general COVID-19 questions and some specific question related to return to the healthcare workforce. So I will now just walk you through our updated data. Every day we get our new updates. Those are put out publicly approximately around this time. I have not seen the updated numbers for today, so please note that these are yesterday and posted on our website. Very soon you should be able to see the data for today. So as of yesterday, we had known 1,132 positive COVID-19 cases based on testing results. We unfortunately continue to have a rising death toll, so up to 29 as of yesterday. In here, as you can see, continue to have approximately 5% positive out of the total negative. So you can see here at over 20,000 negative tests compared to the 1,100 positives or so. And as we continue to message, we know that community transmission is broad, and due to the limitations in the testing materials and guidance on testing, the results here do not reflect the full impact of COVID-19 in our state. So from here, I'm going to turn it over to Dr. Jean to speak to our newest updates to our guidance and respond to some questions and answers that we've received, or questions that we've received.
Yeah, thanks. So we'll just briefly go over the updates to our testing guidance, starting with our recommendations for general testing outside clinical laboratories or in-house clinical labs as well. And just a reminder that we, based on current lab capacity and other considerations, we're still not recommending testing of asymptomatic people and those with mild symptoms that don't require medical evaluation. So the symptomatic criteria would be people with fever, cough, or dyspnea. And our list is now including healthcare workers and first responders, patients with worsening symptoms, patients age 60 or older, and patients with underlying medical conditions. There's also pregnant women on that list, and patients who've had contact with a suspect or lab confirmed case within 14 days of onset. We have removed the criteria about travel to other countries as it's now so widespread in the US. One note will also be, after discussion today, we are planning to add people in congregate care settings to this list. They had been on our other list for testing at the state lab, but we just want to make sure that that is considered as well in case clinicians are involved in care of those patients. So on the next slide, this is the list for the state public health lab, our criteria, and this is really the highest priority groups. So people patients who are in an inpatient facility or are about to be admitted have evidence of viral or lower respiratory infection. And at this point, as a reminder, we have updated this criteria to only require that an influenza test has been ordered. It does not have to have resulted yet. It does not have to be negative prior to approval for COVID-19 testing. The other group is symptomatic people in a congregate care setting, as I mentioned. So long-term care facilities, any healthcare facility, other residential care facilities, behavioral health, et cetera, as well as corrections and childcare would count here as well. The other recent update is we have added to this list for testing at the state lab patients seen at tribal health centers, as well as the couple of Indian health clinics in the state. And those would be any symptomatic people seen at in those settings. And this is just a reminder about precautions for general outpatient testing with swabs, nasopharyngeal swabs, or other nasal swabs. Those can be collected under standard and contact and droplet precautions at a minimum with eye protection. And based on some of the CDC and FDA guidance that changed recently, we have updated the specimens to add nasal mid-turbinate swabs and bilateral anterior nasal swabs as acceptable. And so our guidance, the link is there for the updated guidance. At this point, we've updated that a couple times, 1 or 2 times a week, just based on new information. So please keep checking back. In terms of the questions we got about testing, we had a few questions that I'll answer now. There was another question about sensitivity. The latest I've seen on sensitivity of the PCR testing from swabs puts it somewhere in the 60 to 80 or 85% sensitivity range. And as I've mentioned before, I think it's not a limitation of the PCR, it's a limitation of the specimen collection site and where the virus is at the time of collection. So there was another question related to retesting. If there's a high suspicion of COVID-19 and the test is negative, that would have to be a clinical judgment. And sometimes, from what we've seen in the literature, the initial PCR might be negative. It may take several days for that to be positive. So you can factor that into your decision making about potential retesting. There was a question about with limited swabs, how can we bypass the requirement for flu testing with the state lab? And as I just mentioned, we no longer have a requirement for a negative flu test. However, we still are saying it's flu season. It's very likely that it will be officially declaring the flu season over very soon. We've seen declining percentages of positive flu tests, but we do require that's ordered, at least for now. But again, keep updated because that will probably no longer be the case very soon. And there was finally a question about can we get a list of all clinics, hospitals that are doing drive-up testing? We don't have a list of that this time. We know that many of the major health systems in the state are doing drive-up testing for patients in their systems. Okay, let's move on to personal protective equipment. We recently put out some guidelines on use of PPE in resource-constrained settings, and this is meant to be kind of macro-level guidance for healthcare providers and planning. So we have 4 tiers in here, kind of ranging from general tier 1 without imminent need of or imminent shortages, ranging all the way up to tier 4 recommendations, which would be a truly last resort. Very limited supply setting. So I'll just kind of go through the highlights here. So this is tier 1 approaches with some general recommendations that we be using NIOSH approved PPE, which would be standard in a medical setting. Avoid unnecessary use of PPE by limiting the number of healthcare providers who are entering the room when it's a suspect or known COVID-19 patient. Grouping or bundling activities together. And minimizing direct close contact with mildly ill patients who don't require acute care. Prioritizing PPE by type of activity. So, for example, reserving N95 use for aerosol generating procedures, and using PPE that can be disinfected and reused rather than disposable to the extent possible. Next slide. And considering protective equipment design for use in other industries as determined by federal regulatory agencies that provides adequate protection. There's a link to the FDA there that includes some of the information on that. So there's a lot of other respirators, for example, that provide better protection than N95s, so that could be considered in Tier 1 as well. Moving on to Tier 2. Tier 2 is where we start talking about extended use of respiratory PPE, eye protection, along with decontamination. There's a lot of news and work going on around the country about decontaminating PPE. And the three main types that have been of decontamination that have been shown to work are UV treatment, a vaporized hydrogen peroxide treatment, and a heat treatment. And the idea is that we need to make sure that any treatment we're doing not only decontaminates and sterilizes, but leaves the integrity of PPE intact. So these are the three general groups that have been shown to do that. And we're hoping to start to see that kind of decontamination quite broadly around the U.S., including in Oregon. Let's move on. So Tier 3 would include using PPE beyond the shelf life in lower risk settings. Reusing surgical masks when caring for multiple patients, when there's low transmission risk. These are all things that would not normally be recommended. So just a reminder that this would be when we come to a level of supply concern, you'd be escalating through these tiers. Reusing N95 without decontamination, and then prioritizing unexpired FDA masks for procedures with a higher risk of transmission. So all things that would not be optimal, but would still provide some level of protection and preserve PPE for the most important settings. Finally, moving to Tier 4, again, this is truly last resort situation. We don't expect in Oregon where it's going to come to this. We really hope not, but this would be using repurposed items as PPE, swim masks, ponchos instead of gowns, industrial or sports goggles for eye protection, etc. And then using locally produced or self-made PPE for eye protection, masks, gowns, and there's a whole list there of various things that could be considered.
So we're going to now move, Dr. Smits is going to give us an update on the revised guidance for elective and non-urgent healthcare procedures, since this specifically relates to trying to hold on to PPE where not needing to be immediately used. So Dr. Smits?
I was going to back up one step. We did get some questions about PPE from the last one. I wanted to just answer those before we kind of move on, and then We'll move on to talking about what's considered elective and what's considered not elective. So the PPE questions that you all sent us in the past week, one of them was about how to basically protect your family after leaving a healthcare environment where you may have contact with patients. Obviously, you would want to do very appropriate hand washing, etc. You may wish to disrobe and shower. There's no official OHA recommendation on this at this point. It's whatever your comfort level is. There was a question about whether there's any specific guidance for providers over age 65. And I would also lump into this category any other high-risk groups. Basically, we don't have any specific guidance. It would be the same as for any other provider. Wear masks, gowns, gloves, etc. when dealing with a patient with fever or respiratory symptom. And you may want to consider wearing a mask to all face-to-face visits with any patient, regardless of what their complaint is. There was a question about residential programs and the need for caregivers, or what types of PPE should be used in those settings. Ideally, the ill individual who either had a fever or respiratory symptoms would be wearing a mask, We do realize in some residential programs that might not be possible with people who may not understand the need or be able to comply. And if so, the provider should wear a mask and any other appropriate PPE, such as gloves for injections. Then there was a question about whether an N95 mask should be worn with respiratory patients, or is a regular surgical mask okay? We actually conducted a review, as well as the Oxford Center for Evidence-Based Medicine has also conducted a rapid review, and it looks at this point like viral infections based mostly on flu, regular surgical masks are equally effective to N95. We must put the caveat in there as it hasn't, COVID-19 is too new to have that question really answered. But at this point, it looks like a regular surgical mask for non-aerosolizing procedures, not high-risk procedures, would be fine. So moving on, we had some questions about the governor's order about canceling all elective or non-urgent procedures. In the governor's order, the things that are considered not elective or urgent would be something that would be a threat to a patient's life, or result in irreversible physical or mental harm, permanent dysfunction of an organ, cancer increasing in stage or rapidly worsening condition. So the specific examples that we've been having a lot of questions about include what procedures might be considered urgent. The OHA considers all reproductive healthcare services to be urgent. So putting in IUDs, abortion services, any other services that are required for reproductive healthcare is urgent. It can result in permanent physical or mental harm if reproductive healthcare is not provided. Vaccinations are also urgent healthcare procedures. They prevent the spread of disease in a population. You might consider doing drive-by vaccinations, for example, for child checks or something, but vaccinations should still be continued. Also, any testing or treatment that might be needed to stop the spread of infectious diseases like STIs or other things that might spread in the community would be considered urgent, as well as for anything that might investigate a possible malignancy. So this might affect the stage of a cancer if it's detected, so endometrial biopsy or atypical mole removal. And those are the types of things that are considered urgent. Other care, non-urgent care, can be continued if it does not involve the use of PPE. PPE in this scenario would include face masks, N95 respirators, gowns, and eye protection. And if gloves become short supply, then this would also be canceled. So you could continue to do well-person care, etc. We do recommend that when possible, non-urgent healthcare be done via telemedicine or video medicine, if at all possible.
And this is Dana Harganani again. Just to follow up, we hope that this guidance is helpful to you. We know and recognize that we will not be able to, nor plan to be responding to every specific type of procedure and whether it should be considered essential. And so we really hope that this guidance is useful to you, and given the guidance in here as to whether risk of irreversible harm would occur if delaying that procedure, we really expect local providers to be making those decisions utilizing the guidance as helpful. So we hope this continued update to the guidance help to narrow that for you. So moving on to Dr. Smits, more about masks going outside of the healthcare.
Sure. So this is not healthcare settings. This is masks for the general population. I want to draw listeners' attention to the fact that the governor today issued a new guidance on masks in the general population, and I hope you'll review that. The CDC recommends wearing cloth face coverings in public settings when physical distancing measures are difficult to maintain, but that and in areas that have significant community-based transmission. Do not use surgical masks, N95s, other types of things. Those should be reserved for healthcare providers and first responders and others. So please use this is basically like the home cloth face coverings that, and the CDC has multiple things on their website where they have patterns and other recommendations for making these at home. And following these CDC recommendations, the governor has come out with new recommendations. She recommends definitely continue all of these stay home, save lives. If you do need to go out, maintain 6-foot distance between people, good hand hygiene, etc. She has added to that while you, if you do need to go out, the general public should consider adding cloth face coverings to their protective armament. And again, this is not the medical grade. These would be more of a homemade mask situation.
Great. We're going to move on to have Dr. Schmitz answer a number of questions that related to clinical care and COVID-19.
Sure. This is a little bit of a smorgasbord. These are just questions that have come across. There's a lot of interest in the cytokine storm that appears to be involved in COVID-19 severe disease. At this point, we know of trials underway with corticosteroids, tocilizumab, other immune modulators, etc., but there is no definitive data on these to date. There's been a question about what % of patients are afebrile when they have other symptoms. In published data from China, only about 40% of patients initially had fever, but this rises to almost 90% when patients are hospitalized. They'll at some point during their course have developed a fever. Questions about viral shedding. This is an active area of research. We do not know the duration of viral shedding or whether after someone recovers that viral shedding they might have, whether that's infectious or not. Again, an active area of research is aerosolization of COVID. And again, wear masks when you're seeing patients in the healthcare setting. And then rates of transmission. So the reported R0, which is the measure epidemiologists use to kind of compare or describe how transmissible a disease is. COVID appears to have an R0 between 2 and 3. That compares it to measles, which has an R0 in an unimmunized population of 12 to 18. So COVID is definitely less transmissible than measles, but it does appear to be more transmissible, somewhat more transmissible than seasonal flu. Questions about treatment. There's been a lot of interest in ACE and ARBs and the ACE2 receptors and things like that. We have done updated evidence reviews. There still appears to be the best evidence is that you should keep your patients on their ACE or ARB therapy that they are currently on. We are unaware of any increased risk that those medications would give to somebody, but we do know that there is a risk if you suddenly stop these therapies of adverse cardiovascular events. And a couple of just random questions. Are we tracking healthcare workers who are infected? We have at OHA been actively discussing doing this, and we are planning on adding it to the document that comes out to the public. It's not there yet. There was a question about centralizing coordination of hospital beds in the metropolitan area, the Portland metro area. The governor has declared that bed coordination should occur, and we are hoping that that is happening. And those were that was basically the main clinical care questions. Again, if you have anything specific and you want to send them our way, please do. Please email us or get in touch.
Great. We're now moving to address a specific question that came up regarding healthcare workforce and return to work. So I'm going to turn it to Dr. Jean.
Thanks. So this is a question about basically when can a healthcare provider return to work after a COVID-19 diagnosis and illness. And I will extend my answer to also people with COVID-like illness who may not have been diagnosed, but hopefully at this point, a provider with that illness would be able to get testing. So what's on the screen here, these are the CDC criteria, and they have two strategies they recommend. One is a test-based strategy where you would need to have resolution of your fever and improvement in respiratory symptoms, as well as 2 negative tests using a molecular assay, so that would generally be PCR. from at least 2 consecutive NP swabs collected at least 24 hours apart. So that's the test-based strategy. The non-test-based strategy would be at least 3 days or 72 hours since recovery, defined as resolution of fever without fever-reducing medications, and improvement in respiratory symptoms, as well as 7 days since symptoms first appeared. So whichever is longer. So our recommendation in our clinical care guidance, which is available on our website, healthoregon.org/coronavirus-HCP, and you can find it under the healthcare provider section of that. Our guidance for healthcare providers is for the non-test-based strategy. That's what we recommend, but it's certainly up to employer and infection preventionists and occupational health to determine what might be appropriate based on your resources and your settings. So our recommendation, just to be clear, is for healthcare providers with a respiratory illness, including suspect or confirmed COVID-19. We recommend work exclusion until at least 3 days, 72 hours have passed since recovery. And we define recovery as resolution of cough and fever without the use of fever-reducing medications. So it's a very simplified exclusion criteria. And I would add to that the question about viral shedding, we still don't know the duration of viral shedding. I really have not seen any evidence of post-symptomatic transmission. Clearly, an asymptomatic provider who's recovered. So we think the 3 days after symptoms is a pretty good, pretty safe measure there. The problem with the test-based strategy is we do know that PCR can be positive for at least a couple weeks in some cases after recovery. And that may be just because there's still some viral RNA hanging out there. It doesn't mean there's a high risk of transmission. The studies we've seen also suggest that the viral load is highest earlier in the symptomatic period and tends to decline during the symptomatic period and then keep declining through recovery. So just to add to our recommendations, we also recommend after returning to work to wear a face mask at all times until 14 days after the date of onset. So this is kind of an additional recommendation. And then that the provider be restricted from contact with severely immunocompromised patients like transplant or hem-onc until 14 days after illness onset. And of course, adhere to all the hand hygiene, respiratory hygiene in the infection control guidance. And then ongoing self-monitoring for symptoms and seek reevaluation from occupational health if symptoms recur or worsen. So I hope that answers that question.
Perfect. So we share this routinely. We want to always give your attention to our statewide emergency registry of volunteers in Oregon. I will let you know that we have actively been engaging with that volunteer workforce. There's been training happening on some focused efforts, and we continue to want to have that at the ready for any ongoing needs, particularly both during a surge situation, but also for ongoing surveillance. And so if interested, we definitely direct you to continue to consider signing up to this website. I should also have the nursing board here. We know that many of our licensure boards have made some interim changes to allow for additional workforce during this time of the COVID-19 response. We encourage you to look up your licensing boards to check out what those changes have been. We are also collecting those here at the OHA, and if we have a consolidated list, we will certainly continue to bring that forward to you. But please do look up your own licensing board to see what those changes have been. And again, we always invite you to our website, which has the most up-to-date guidance. We will try to always highlight where we've made new updates or we've created new guidance. Those are listed here on our coronavirus information webpage for healthcare providers, as you see listed here. In addition, we have continued to monitor this email address so that if you have questions that you didn't think of during the webinar, or you have specific topics you'd like to hear more about, please do email us at this email address. Do note that we are not planning to provide individual responses, but are monitoring it to provide information for us on updates we want to bring to our next webinar. I am going to pause. I think Dr. Jean has some additional updates, and then I also want to close out by kind of looking ahead at where we are.
Yeah, I was actually just going to add a little bit about our numbers. You know, we kind of went through, Dr. Harganani went through some of our latest case numbers, but just wanted to highlight some of the information that's available and will be coming available on our healthcare provider's website. We've already got an interactive visualization showing our epi curve, which is of course the curve that we all want to flatten. So that's now available. And the caveat with that is it's really most reliable looking 10 days back and before that, because it's listed by, cases are listed by date of symptom onset, and of course it takes a while for somebody to get sick, to get tested, get test results, and for those test results to be reported. So the case counts for the past 10 days on a rolling basis are always going to be an underrepresentation of the true case counts. So with that caveat, looking back to the reliable data we have, we can't say we're flattening the curve yet, but we can say that we are not seeing any kind of exponential increase. And combined with our modeling data, we're optimistic that we're cautiously optimistic that we're starting to get to the point where we might be plateauing or seeing a decline in cases. And that lines up with some of our data from our emergency department visits, which have now been declining for over 3 weeks. And for the past 2 weeks, the COVID-like illness visits have also been declining at EDs in Oregon. So that's certainly good news. The next week or two is going to be very telling to see what our case counts continue to do. But we're hopeful that social distancing or physical distancing is really making a difference here.
Just a couple additions to that. Thank you, Tom. We also collect specific information outside of our epi information that Dr. Jean just referred to. We collect data directly from our hospitals across the state, approximately 66 hospitals across our state, to understand currently how many patients do they have in their hospital at the time daily of reporting who have either COVID positive results or are suspected COVID patients. And that number has been continuously rising over these last couple weeks, and currently those numbers sit at about 464 as of this morning. We do publicly report that. If you go to our healthcare provider's website, we produce, at the very bottom of that website, we list our daily updates, public facing, that includes the epi curve that Dr. Jean was just, includes our information about emergency room visits. There's some additional now data available around our epi curve, for example, and those hospitalization numbers. So we, again, have a lot of tools for us to understand what is happening in our state with regards to that curve, where we might stand, and a lot of modeling happening that we are following that suggests, again, to be cautiously optimistic that we won't see for sure for example, the impacts that some of our other states are having. So please keep staying tuned. Again, these next 1 to 2 weeks are going to be really helpful to us to see how this data changes, to get a better sense of what's to come ahead. I want to just leave you with one final request for your help. We know that as these data continue to be published and perhaps start to be looking more optimistic for our state, and in addition, as we're facing what looks to be a beautiful week for Oregon weather here in April, that we are really asking for your help to your families and patients and friends to ensure that you continue holding to our physical distancing policies. We know that this has been, we expect this has been a significant part of how we have had a better outcome thus far in our COVID-19 experience. And so it is really important to continue to hold to those physical distancing measures. If you go out, please do spread out. And ultimately, we know that if you stay home, you will be saving lives. And we know that the state and the governor's office will be continuing to look at this data over the coming weeks to think about what the future looks like in those policies. But please now, we really hope that you will help spread that message to stay home and save lives. So with that, we will continue to look at your questions and bring forth further content. I want to remind everybody that every Thursday from 12 to 1, there is a Project ECHO weekly virtual interactive session hosted by the Oregon ECHO Network at OHSU. Myself and often my colleagues here, as well as Dr. Jen Vines, our Multnomah County Health Officer, and other invited content experts engage in producing the information. Some of it is a repeat, and also there are different tools that Project ECHO provides in terms of also being able to connect with other providers on the chat live. So we encourage you to consider joining us again for that on Thursday. Just one last thank you to all that you're doing on the front line during these stressful times. Please take care of yourself, and we appreciate all that you do. Have a great day.